The main challenge is that people have orthopaedic surgery, so let's take knees and hip replacements, and 45% of people have knee replacements, and 35% who have hip replacements say that their condition didn't improve or actually got worse after the surgery. And we believe that it's actually all about making sure that people have shared decision making with the clinician, and they're much better able to make the decision about whether to have surgery or not. And Chloe will talk a bit about actually what we did.
Yes, so we created a multifaceted education approach to really try to ensure that the patient was in control of their healthcare journey and that care was tailored to their needs. And in order to do this, we wanted to embed a culture of shared decision making and collaborative care. We know that shared decision making is important to patients. They want to be more involved in decisions about their care. We also know that both clinicians and patients overestimate the benefits of medical intervention, surgery for example, and underestimate the harms. We designed a multifaceted education approach which included training in motivational interviewing and shared decision making. We created a team of champions, so clinical champions who were able to offer peer support, reflective practice within their pathways. We also work very carefully and closely with our patient partners. We're lucky enough to work with a patient director in our organisation who has a team of patients as partners, and they were involved in the co-design and the co-delivery of that training. We have supported the formal training with informal workshops, masterclasses within the MDTs, and we also do other things within our system to support patients being in control. For example, we write after the appointment directly to the patient. So rather than writing a letter about a patient to a GP, we actually address the letter to the patient, really detailing the treatment options, what matters to them, and the next steps in a way that they want, need, and understand.
So our project, which was putting patients in control using shared decision making, the outcome of that has been, even though we got more referrals into the service for orthopaedic surgery or orthopaedic conditions, that we we used the conversation with patients, and we've actually sent on 7% fewer patients to have surgery just by them making a shared decision making with the clinician. Not only that, the patient satisfaction has gone up. 12% more patients said that they were more involved in the conversation than beforehand. And because fewer people are going on for surgery, only the ones that really need surgery are going for surgery, which means they get seen quicker. So patients are waiting now below the national average to actually receive surgery in the first place.
Our objectives for the coming year are not to kind of rest on our laurels. We know that we have come so far as an organisation, but we know that we can improve. We continually support our clinicians to not only consider evidence-based practice, but also consider shared decision making, so patient preferences when working with a patient to understand what direction they might want to go in terms of treatment and care pathways. We will also looking in the next year to support patients to come to their appointment ready to take part in a very different conversation, which will feel much more collaborative and less paternalistic and didactic, probably than other medical appointments that they've been to in the past. We really want patients to come really ready to be able to have a conversation where they are fully part of decision making. And we also want to work with our local STP to think about how we reduce unwarranted variation in our MSK services, but also support our other musculoskeletal services working across our STP so that we can together reduce unwarranted variation across our region.
One of our objectives for the next year is also to share our learning well beyond Sussex MSK and Sussex. So we want to develop a package that can be used across the country. We think that so many places are looking at reducing thresholds for surgery, which probably needs to happen, but at the same time we think that savings for the NHS could be had by just putting patients in control and not focusing on what the patients do, but focusing on what what clinicians do and how they have conversations with patients. So particularly the next year, we want to work right across Sussex, into Surrey and nationally really about spreading what we've learned and how we're doing it.
I think it might be a nice opportunity to thank the staff that work in our organisation. They've really embraced this new way of working. We spent a lot of time engaging with our teams, really understanding their beliefs and values around shared decision making, what it meant to them, their strengths and their weaknesses, and we work hard as an organisation to really model those collaborative behaviours across all aspects of the organisation, so that clinicians feel heard and listened to, and then therefore they're much more likely to go into an appointment with a patient and work in a collaborative way.
The other thing I wanted to add was that there's a lot of focus on saving money in the NHS at the moment, and rightly so. We've got to spend taxpayers' money wisely. I think what we've done is been able to improve outcomes for patients, improve patient experience, and save money. So we've improved experience, we've improved waiting times. The staff are happy, and also we've compared to what would have happened before, we've saved the local health economy close on £8 million in the last 2 years.